Okay, I think we can get started. It's 2 minutes after 12:30. We have been asked to present at our monthly case conference today. My name is Layton Lesmana, one of the staff at Klion Clinic. I'm a pediatric hematologist, oncologist, and also a clinical geneticist here. Presenting our case today will be our third-year pediatric resident, Dr. Reem Akiely, who is also an aspiring pediatric hematology oncology fellow. So take it away.
Thank you for the introduction, Dr. Lesmana. Thank you everyone for having us today. We're very excited to be sharing this case with you today. And I'm not sure if there are other trainees or like students in the audience, but I always like to start by remembering how I used to remember the causes of eosinophils as a med student. I used to just say simply worms, wheezes, and weird diseases, but I realized that it's much more complex than that. And I think most of our talk today will be more related to the weird diseases portion. So I guess we can get started. Oops. So we don't have any relevant disclosures or conflicts of interests. And the objectives of our talk are a couple. We wanted to kind of recognize the wide differential diagnoses behind pediatric hypereosinophilia and to distinguish between reactive, clonal, and idiopathic etiologies. And at the same time, we wanted to share the importance of comprehensive immunologic, infectious, and hematologic workup in the evaluation of hypereosinophilia in children. And then lastly, we wanted to discuss the importance of and the implications of knowing the trying to know the etiology behind the hypereosinophilia, as it can dictate the management strategies and dictate the need for referral to subspecialty care. Sorry, getting stuck. So to talk briefly about our patient, he was a 5-year-old at that time. He was a 5-year-old boy who had history of APS type 1, autoimmune polyglandular syndrome type 1, and he was status post-liver transplant in 2019 due to acute fulminant liver failure. He had presented to our combined immunohematology clinic in November 2023 with hypereosinophilia and an absolute eosinophilic count of 17,000. Some background about this patient. He had fulminant hepatic failure at the age of 1 year, and as part of evaluation for the hepatic failure, he got whole exome sequencing that identified biallelic mutations in the ER gene, thus making the diagnosis of autoimmune polyglandular syndrome type 1. He ended up getting a living donor liver transplant the same year, and he's also noted to have solitary kidney and a confirmed egg allergy being followed by allergy and immunology. In terms of post-transplant management, by the time he got to our clinic, he was still on the immunosuppressive therapy regimen of CellCept or mycophenolate, tacrolimus, and a low dose of prednisolone. The hepatology team had initially found hard time tapering the prednisolone due to ongoing liver enzyme elevation. But by the time he presented to us, they were following a steroid wean due to growth concerns and stunting in weight and height. He did not have any concerns for rejection in any of his liver biopsies, with the most recent one being 10 months prior to presenting to us. Some information about the transplant and serologies. Both the donor and the recipient were EBV positive and toxoplasma negative. However, the donor was CMV negative, HSV negative, while the recipient was positive for both. The donor was noted to be strongyloides IgG positive and had been treated with ivermectin, and the patient's strongyloides IgG was indeterminate in the year after following transplant. Besides the liver transplant and the liver biopsies, he did not have any other relevant surgical history to share. Oops, sorry about that. In terms of review of system, by the time he came to our clinic, he was very well appearing. The only reported positive symptoms were the stunting in growth, in height and weight, and also some on and off vomiting that has been followed by gastroenterology, but no fevers, no chills, or other constitutional symptoms or other GI symptoms. Of note, prior to presenting to us a week prior, to be specific, he was recently admitted in an outside hospital for fever in the setting of immune suppression. So he was started on empiric antibiotics antibiotics and also received stress dosing. By that time, the blood cultures were negative and he tested positive for rhinoenterovirus. It's important to note that even prior to like that admission, the CBC on that admission also was a short marked eosinophilia of 7,000. In terms of social history and travel, he did not travel outside Ohio at that time, only went to Columbus, and no animal exposure apart from dogs. For his medications, as we said, he was on a steroid taper, he was on tacrolimus, Celsip, amlodipine for hypertension, and just the same day he was started on amoxicillin for acute otitis media. On examination, he did not have any skin rash, any notable lymphadenopathy, or palpable hepatosplenomegaly. Just to take a step back and to remind ourselves about autoimmune polyglandular syndrome, especially that it's rare in this age group. Type 1 of this autoimmune polyendocrine syndromes is related to mutations in the AIR gene, as we discussed. And then the main manifestations in these cases are usually related to pituitary, with Addison's disease being the main manifestation, but also hypoparathyroidism, putting them at risk of hypocalcemic crises. And in terms of infection risk, they're mostly at risk of infection, at risk of chronic mucocutaneous candidiasis. Other manifestations which are relevant to our patient include other organ system involvements, including hepatitis, which happened with our patient and was actually his the way he presented, as that led to his diagnosis of APS type 1. But other involvement can include the pancreas, the lungs, the GI tract, and also the skin and mucosal membranes. As we said, it's usually later in childhood and adolescence, and the treatment is mostly directed towards hormone replacement in Addison's disease, but also immunosuppressive therapy for cases that involve hepatitis, nephritis, or pneumonitis. In terms of complications, adrenal crises and adrenal and hypocalcemic crises are key complications that are noted, but also cancers in the gastrointestinal tract. Now back to our patient and the CBC. When he presented to the immunohematology clinic, it was notable for a white BC count of 24,000, 70% differential of eosinophils, and that made the absolute eosinophil count being markedly elevated at 17,000. Other than that, the hemoglobin was within normal limits, and the platelets was also within normal limits of 334. We tried to look into his prior trends, and the highlighted number is the day of presentation to us, the 17,000. And we realized that even prior to the referral to immunohematology, he kind of had marked elevations in his absolute eosinophilic counts ranging between 2,000 to 3,000 in the 2 years prior, and that was starting following transplant. He didn't have that significant increase to the 17,000, but we just noted this trend and we kept it in mind while we were doing the evaluation. We also noted the spike to the 10,000 in the end of the year 2022. Before we talk about like our multidisciplinary evaluation and the next steps that we took, we wanted to just leave some room to the audience and see if anyone would like to share their thoughts on what would be main differential diagnosis list would include at this time, and how would you proceed?
It's something with pediatric hypereosinophilia.
Yeah, so if you guys have questions or clarifying questions about the history, feel free to unmute or also put it on a chat. We just wanted to engage your response on what would you do in this type of situations. So this is a 4 or 5 years old male who has known APS type 1 status post liver transplant on chronic immunosuppressive therapy that had pretty high eosinophil counts, up to 27,000.
Any symptoms of like organ failure with the high eosinophils, or any symptoms of atopy or allergy, or any history of that in the family?
Go ahead, Reem. I think you have the answer to that.
Yes. So we'll get to the organ involvement as part of the workup, but in terms of atopy, at that time he did not have any history of atopy or known asthma diagnoses, but later in the course there was some concerns. However, the impression was that they might actually have been a result of the hypereosinophilia rather than a true atopy. He did have history of eczema though, and the egg allergy was notable as well in his history. That was confirmed and followed by allergy and immunology closely with no recent exposures.
There's question, what was his IgE, which I think will be on the subsequent slides. Any parasitic infections, any GI symptoms that the patient presented, which I think we did mention that he does have intermittent abdominal pain and diarrhea at the time of presentations.
Can I
No.
clarify one thing, Adrian? This is Dr. Alakrishnan. I'm his hepatologist. You know, we were worried about, so the reason we think what led to his liver failure was an RSV infection he had just immediately prior to his presentation. And he had a positive smooth muscle antibody of 1 in 40, not significantly high. So we thought he had fulminant liver failure from a fulminant autoimmune hepatitis, possibly triggered by RSV, is a theory. He did have changes in his biopsy were subtle, nothing to say rejection, some periportal inflammation, which raised concerns with his elevated liver enzyme. But he had some recurrence of his autoimmune hepatitis versus what we call as post-transplant hepatitis in the liver. And which is part of the reason we left him on a touch of steroid and a restarted CellCept with an aim to wean the steroids down and take him up because of his growth, as Reem kind of mentioned.
Thank you, Kristen, for clarifying. All right, I think we can move on to the next slides.
Thank you, everyone. So we wanted to just kind of discuss some terminology to differentiate between common terms being used in this topic. So eosinophilia itself is when the absolute eosinophilic count exceeds 500. However, hypereosinophilia is when the absolute eosinophilic count exceeds 1500. Traditionally, this term should involve the measurements on at least 2 occasions, at least 4 weeks apart. However, this time interval can be waived if there's concern for rapid organ damage, and that is common in these scenarios. For tissue hypereosinophilia, if it's involving the bone marrow, then the cutoff is more than 20% of bone marrow involvement, or if it's another tissue, to have extensive tissue infiltration by eosinophils or marked deposition of eosinophilic granule proteins. Now, to give the term of hypereosinophilic syndrome, then in addition to hypereosinophilia, we should expect to have end organ effects due to eosinophilic infiltration or granule deposition with another attributable
Just looking at my nail vocabularies, don't mind me.
There are multiple classifications for hypereosinophilia or hypereosinophilic syndrome. We'll go by HE. HE is for short, but the easiest and most simple way for this discussion is to classify as primary or clonal or neoplastic versus secondary or reactive, and also finally idiopathic. In terms of primary or clonal HE or HES, the etiology is usually a neoplastic expansion of eosinophils from myeloid or stem cell origin. One big group under this umbrella is the myeloid neoplasms with eosinophilia involving tyrosine kinase mutations, including platelet-derived growth factor alpha and beta fusion rearrangements, fibroblast growth factor receptor 1, and JAK2 mutations. Other subgroups include the chronic eosinophilic leukemia, acute myeloid leukemia, MDS, and systemic mastocytosis. It's important to note that in adults, these comprise almost 11% of HE cases. However, in pediatrics, it's less, as it only accounts for 8% of these cases approximately. As for secondary or reactive causes, we wanted to spend some time on this slide as it's very relevant to pediatrics, but also to our patient as well. Infections is a big group, and mostly, as some of you had mentioned, parasitic or helminthic infections, including strongyloides, but also other helminthic infections like schistosoma, entamoeba, and trichinella. In terms of viruses, HIV has been implicated, and fungal infections like histoplasma, cryptococcus, and coccidioides authorities have been implemented as well, in addition to TB. Allergy, as you guys have mentioned, is also implicated, including asthma in general, allergic rhinitis, atopic dermatitis, but also allergic bronchopulmonary aspergillosis. Autoimmune disorders have been associated with reactive hypereosinophilia, including IBD, celiac, but also SLE, Sjogren's, and multiple others. As for medications, the associations is usually through Drass syndrome, but sometimes only eosinophilia, and implicated medications are aspirin, NSAIDs, and many antibiotics. For malignancy, we talked about clonal proliferation of eosinophilia, but other malignancies, specifically lymphomas and solid tumor, can result in reactive eosinophilia. And one common, very well-known association with hypereosinophilia is adrenal insufficiency, including Addison's disease or primary adrenal insufficiency. And there are multiple theories behind that, but one of them is that the lack of steroids can actually result in the normal suppression of eosinophils and improving their survival. And in terms of immunodeficiency syndromes associated with hypereosinophilia, known associations include hyper IgE syndrome, Wiskott-Aldrich, and Almond syndrome, which is a subtype of SCID that involves lymphadenopathy and hepatosplenomegaly with skin changes and erythroderma. There are multiple others, more rare associations that are not very relevant to our talk, but they include solid organ rejection. This one is relevant to our talk, but other than that, like cholesterol emboli and more rare diseases like humoral disease, which involves mostly skin lesions with lymphadenopathy. Okay, one thing I wanted to highlight, though, related to the immune deficiency or immune dysregulation syndromes, I know that our patient had APS type 1. APS type 1 by itself has not been reported to be associated with hypereosinophilia. However, one very important connecting point is the risk of adrenal insufficiency or Addison's disease that can result in hypereosinophilia. As for idiopathic hypereosinophilia, it's usually a diagnosis of exclusion that cannot be made until we've done the workup necessity and have proved that the patient had sustained hypereosinophilia with organ damage attributable to the eosinophilia and have excluded the reactive causes of eosinophilia or clonal expansion. Now, when we go back to our patient, it was not an easy case just because of his complex history, which made the differential for him from the start broad, including his risk of neoplastic diseases, one like primary neoplastic disorders, but also secondary like lymphomas and solid tumor, especially that our patient had chronic EBV viremia, thus putting him at risk of post-transplant lymphoproliferative disorder. Additionally, given his immunosuppressed status, he was at risk of infections, including helminthic and parasitic infections. Mentioning his allergy history, allergy and atopy was also something to consider. And also, given his known immune dysregulation, we thought of immunologic disorders. And also, he was on multiple medications that put him at risk. And as we talked about, EPS type 1 itself is not an association. However, adrenal insufficiency is. And then finally, we would not have came to the conclusion of idiopathic hypereosinophilic syndrome before discussing the prior list. Some of you have mentioned evaluating foot and organ damage, so I think we can move forward to discuss our approach for this patient. We started with basic oncology evaluation by doing peripheral blood studies. As we did flow cytometry that was negative for blast proliferation, we sent an NGS panel on the peripheral blood that was negative, and I wanted to mention that this includes platelet-derived growth factor alpha, JAK2, and fibroblast growth factor that are implicated in the myeloid or clonal reasons of hypereosinophilia. We did a separate fluorescent in situ hybridization analysis for platelet-derived growth factor receptor beta, and it was also negative. Through our immunohematology clinic, we facilitated the end organ evaluation, starting with cardiac evaluation. Initial troponin testing was mildly elevated at 30, but then it was normalized on repeat testing twice. We did an echo that showed normal function and structure. We did recommend spirometry that was completed and showed normal limits. However, it was completed a few months later due to complicated course and multiple hospital admissions, as we will see in the next few slides. We had recommended bronchoscopy and EGD in coordination with our pulmonary team. However, these are still not completed, and we'll get to that in a bit as well. Additionally, we proceeded with the following evaluation. Starting from the top right, we did the immunoglobulin subclasses that were mostly within normal limits, and I wanted to highlight the IgE being normal. As some of you have mentioned, it's an important part of the evaluation, as it kind of points toward more allergies or atopy as a cause behind the hypereosinophilia. Part of the evaluation was vitamin B12 as well, which was elevated at 1900. It's important within this discussion, as elevated vitamin B12 with hypereosinophilia has been more associated with the clonal or the reactive lymphocytic causes of hypereosinophilia rather than the atopy or the allergic. But I wanted to also highlight that the caveat to this case is that vitamin B12 can be falsely elevated in patients with liver disease. So we kind of were cautious with interpreting the vitamin B12. In terms of the lymphocyte subset panel, it was mostly within accepted limits. However, when we send the cytokine profile panel, we can see that the interleukin 5 is highlighted because it was elevated, and interleukin 5 is one of the cytokines that drives eosinophil proliferation. This, in addition to the elevation in interleukin 10 and interleukin 13, kind of points towards a more T helper 2 skewed balance of the T helper cells. In terms of the interleukin 2 receptor, it's elevated, but it's a non-specific marker of T cell activation, which might have been related to his multiple respiratory illnesses during that time of evaluation. Our allergy immunology colleagues also helped us complete his allergy evaluation. As we have mentioned before, he had known egg allergy that included an anaphylaxis episodes in 3 years prior, but there was no recent exposure prior to this presentation. His tryptase was within normal limits, and his blood allergy panel was completely negative. For relevant infectious evaluation, we mentioned he did not have any travel or activities to suggest increased risk of parasitic infections. However, we had mentioned that the donor had been Strongyloides IgG positive, was treated with ivermectin, and initially the patient's IgG serology was indeterminate. We repeated the IgG by the time of presentation, and it was negative. We completed cryptosporidium giardia testing for antigen that was also negative, and although ova and parasite exam was ordered, but it was not completed. From GI perspective, our gastroenterology and hepatology colleagues closely followed this patient. His liver enzymes remained within accepted throughout course, and as we said, his most recent liver biopsy 10 months prior to the presentation was reassuring against rejection. Imaging during that time with liver ultrasound was also reassuring for the transplanted liver. In terms of endocrinology evaluation, which was very important in our patient, as he was already an established patient with the endocrinology team because of his APS type 1 syndrome. They started with basic hormonal profile that showed extremely low morning cortisol at 1.8. This was suggestive of adrenal insufficiency. For his case specifically, the likely etiology was secondary adrenal insufficiency due to prolonged corticosteroid use, although we wanted to keep in mind that patients with APS type 1 are also at risk of primary adrenal insufficiency. Further evaluation was planned for primary adrenal insufficiency, but it was kind of delayed due to the admissions. However, it was concluded on multiple later occasions that his ACTH levels remained to be normal to low, this being suggestive of secondary, not consistent with primary adrenal insufficiency. Thus, so far, the impression was that it's secondary due to the prolonged steroids rather than primary adrenal insufficiency due to APS type 1. Also touching on the medications implicated in hypereosinophilia, as we said, most of the time it's part of DRESS syndrome, and the most implicated medications are the sulfasalazine, allopurinol, some antibiotics, anticonvulsants, many anti-inflammatories, NSAIDs, and aspirin. But in our patient specifically, although he did receive antibiotics the week prior, the eosinophilia even prior to that preceded the antibiotics, and at the same time he didn't have rash or organ dysfunction that we were aware of at that time. Thus, this made DRESS syndrome less likely. At this point, just given the reassuring basic oncologic eval and the endocrinology evaluation pointing towards secondary adrenal insufficiency, the impression was mostly a reactive hypereosinophilia due to adrenal insufficiency. However, the patient did not have a very smooth course afterwards, as he had multiple admissions starting the day after his clinic visit. He had a fever, thus was admitted as a sepsis rule-out. His white blood cell count on admission was 34,000, and his absolute eosinophilic count was 10,000. He ended up testing positive for rhinoenterovirus again. He was started initially on broad-spectrum antibiotics, and because he was on a steroid taper, he received stress dose of steroids. Within 1 or 2 days of admission, his white blood cell count decreased to 14,000, and his absolute eosinophilic count decreased to 2,500. In the following 2 months, he had multiple hospital admissions, mostly for respiratory viral illnesses, including influenza, rhinoentero again, and RSV. Each of those episodes, just because of his presentation with febrile illnesses, required stress dose of steroids, whether prednisolone or hydrocortisone, usually led by our endocrinology colleagues. And his absolute eosinophilic count continued to trend down with these episodes, and at some point transiently normalized, but he most of the time remained steroid dependent. During one of the illnesses or one of the admissions, he developed wheezing that did respond well to bronchodilators, and he subsequently established care with pulmonology and was diagnosed with mild intermittent asthma. However, our pulmonology team had mentioned that without a clear, more dedicated evaluation, it wouldn't have been possible to know if this is a true intrinsic asthma versus a manifestation of his hypereosinophilia. In late January of 2024, he was hospitalized for a norovirus infection and again received stress dosing with steroids. By the time of discharge, endocrinology helped us to initiate a structured, very slow wean over a 6-week period. This prolonged course of multiple infections and admissions requiring stress doses is what led to a very prolonged and delay in him being off steroids. By February 2024, he was admitted again with a reactive airway disease or asthma exacerbation triggered by influenza V that responded to bronchodilator, Tamiflu, and stress dose steroids. And he was discharged again to continue the hydrocortisone wean as planned by endocrinology. By the beginning of March of 2024, he was completely off hydrocortisone, as led by endocrine. However, 2 weeks afterwards, his absolute eosinophilic count rebounded to a peak of 27,000. Thus, he was advised to come back to the immunohematology clinic. By that time, he was asymptomatic without any respiratory or abdominal symptom or GI symptoms, and this trend in the eosinophils was concurrent with the rising EBV viral load exceeding 1 million. Just prior to him getting to our clinic within few days, he had brief episodes of loose stools, so mom had given him 2 doses of stress steroids at home. So by the time he did come to our clinic, the absolute eosinophilic count did improve down to 4,000. And this shows the second spike of the eosinophil. So as we said, by late March, it was 27,000. The immediate decline is probably related to the stress dosing given at home, but then it spiked again to almost 18,000. At that point, the multiple teams got together and had multiple discussions that led to kind of a more comprehensive evaluation and higher level of concern given the failure to maintain the trend of low eosinophilic count or stable count despite a slow wean or management of adrenal insufficiency. Thus, the plan was to repeat the workup. We repeated the tryptase that was still within normal limits, repeated troponin to make sure we're not missing an organ dysfunction that was still negative. Stool ova and parasites was completed and was negative. Repeated strongyloides, IgG was also negative. We repeated the cytokine panel that was kind of comparable to the initial one with elevated levels of interleukin 5, interleukin 10, and also interleukin 2 receptor, which again overall kind of pointing towards a T helper 2 skew in the CD4 helper cells. We also completed an autoimmune or rheumatologic evaluation just to cover the one of the common reasons of reactive hypereosinophilia, and that was overall reassuring and negative. At that point, because of the significant increase in the eosinophil count, we ended up doing a bone marrow aspirate. Flow biopsy, flow cytometry was again negative for blasts. Acute NGS panel was also negative. Platelet-derived growth factor receptor beta rearrangement by FISH was also negative, and BCR ABL rearrangement by FISH was also negative. We evaluated for B-cell and T-cell clonality at that time, and both were also negative. For the high level of concern for occult malignancy or lymphoma, we completed a whole body PET-CT that was reassuringly negative as well. By that time, and after ruling out malignancy, most of the discussions were directed toward him being like this case being not a straightforward case, multiple driving risk factors. And the conclusion was that his case was likely multifactorial. One of the causes implemented, which we had covered, it was the steroid taper. And as we said, the transient low cortisol can result in rebound rise in eosinophils. There has been reports describing tacrolimus and CellCept as potential agents resulting in T helper skew as well, which could contribute to the eosinophilia. His atopic predisposition, as we said, apart from eczema, was not very strong, especially with the IgE levels being normal. However, they have been implicated in to have T helper 2 bias as well. And then finally, there have been some reports that discussed intercurrent infections or multiple viral illnesses further suppressing T helper 1 and triggering epithelial alarmins release, resulting in T helper 2 skew. So the management approach for this case was a multidisciplinary discussion that resulted in multiple changes to try to avoid the prolonged courses of steroids, while at the same time acutely manage the very high counts of eosinophils. So to summarize the management of this patient, once we hit the peak of the 25,000 of the 27,000, and as soon as the bone marrow was negative for malignancy, we started prednisolone, which is the standard steroid to use, and at a dose of 0.5 mg per kg per day. This continued for 4 weeks and resulted in rapid eosinophil suppression until we complete our evaluation and management approach. While our teams were tapering the steroids, we wanted to make sure that we're not risking the liver at the same time. So our hepatologist had added oral budesonide or Intercord daily, and the rationale behind that was it's a steroid with a very high first pass metabolism, thus it's more liver targeted with minimal systemic immunosuppression. Another change to the immune modulation regimen was trying to omit CellCept from the regimen to lower the T helper skew as well, while at the same time maintaining immunomodulation with tacrolimus and budesonide. This has resulted in preserved hepatic function and stable eosinophils, and by June 30th, the patient was off prednisolone, and by July 14th of the same year, he was off hydrocortisone, and the endocrine team has led the way to make sure that it's safe and slow. He did not require stress dosing, and if we see the trends in his eosinophil in the following few months, it has maintained the levels between 1 to 2,000. Now, there are ongoing multidisciplinary discussions with this patient, especially with continuing the evaluation with pulmonology and considering bronchoalveolar lavage and EGD, given that the eosinophils are still markedly elevated at this point. And then the other thought that the teams discussed was to consider targeted therapy with monoclonal antibody against interleukin 5, which is mepolizumab, if the eosinophils proved that they would rebound or that the counts would worsen. We wanted to spend a few minutes just to kind of discuss how not all cases of hypereosinophilia can be straightforward, and this is one example. And this patient's course until the stabilization had kind of took almost 6 to 7 months. And involved multidisciplinary team evaluation. One of the review articles that we found helpful for this discussion is this review article that includes a diagnostic and management approach for pediatric cases of hypereosinophilia. And as we can see, given that the most common causes of hypereosinophilia in pediatrics are usually secondary, it's important to evaluate for these cases, for these causes from the beginning, including infections, allergy, medications, and solid tumors, and also adrenal insufficiency, as in our case, while at the same time making sure that the elevated eosinophilic counts are not resulting in acute end organ damage. That's why we started with the troponin, echoes, and also considering imaging depending on the lung and the organ involvements. And with our patients, pulmonary function test and bronchoscopy, since he started having some reactive airway disease symptoms, and if other organs are involved, like the GI tract, heart, sinuses, nerves, to consider tissue biopsy directly. It's then recommended to consider evaluating for blood and bone marrow to rule out clonality or clonal reasons of hypereosinophilia, starting with the B12 as we discussed, tryptase that would point towards allergic causes similar to IgE, while the other rearrangements like PD, GFR, alpha and beta fusion genes, and T cell receptor rearrangement that would make us be more concerned toward clonal causes. For the second part of this algorithm, it's more directed towards targeted therapies for each subset. For example, if we look at the left, if we're dealing with myeloid lymphoid neoplasms with tyrosine kinase gene fusions, then imatinib is known to be standard treatment for the platelet-derived growth factor receptor alpha and beta fusions, with plus minus steroids if there's cardiac involvements. Other agents have been described as well, including JAK inhibitors for cases that involve JAK2 fusions, and multiple monoclonal antibodies, as we can see here. At the same time, if we look at the middle, if the hypereosinophilia is driven by myeloid neoplasms without tyrosine kinase gene fusion, then the distinction would be dependent on the presence or absence of significant blasts. And if there is, then the treatment would be directed towards managing the underlying disease like AML or MDS, as per the standardized protocol. Where if there is clonality like chronic eosinophilic leukemia, other agents that have been described include hydroxyurea, but also PEG interferon as well, and some clinical trials that have been implicated. Imatinib has also been described in some cases in these subclass of clonal eosinophilia. If there is no concern, there is no concern for abnormal T cell immunophenotype or no clonal etiology, then the question that we need to ask ourselves, is there an end organ damage or not? Because if there is end organ damage, then what's important to mention is that mepolizumab, which is the interleukin 5 monoclonal antibody, as we discussed, is approved for idiopathic hypereosinophilic syndrome if there is end organ damage. Other agents that have been described are hydroxyurea and PEG interferon and imatinib, but as we discussed before, corticosteroids remain the first treatment option, just to control the rapid rise of eosinophils. And then lastly, if there is no end organ damage, but there is idiopathic hypereosinophilia without a clear cause, then some reports have suggested monitoring or watchful waiting approach if it's indicated, with close follow-up to make sure there is no development of end organ damage. We wanted to share this case just to highlight a couple points, and starting with the reminder that secondary reactive eosinophilia is more common than primary. However, it's very important to make sure we're not missing clonal disease, and that can start with oncologic evaluation on the peripheral blood, and if needed, bone marrow, as in our case. As we proved in this case, the management was not possible without a multidisciplinary team evaluation and cooperation to make sure that we are treating his hypereosinophilia while at the same time maintaining his liver function. Third thing is to highlight the importance of adrenal suppression as a reason behind eosinophilia, but at the same time, usually the levels of hypereosinophilia and adrenal suppression are not usually this high as in our case, and that made the teams think more towards the multifactorial etiology in this case, which led to the conclusion that an imbalance between T helper 1 to T helper 2 can contribute to eosinophilia as well, and some of the drugs implicated include tacrolimus, CellCept, and also infections as well. This is just as a joke. And we wanted to leave some time for discussion, and I really appreciate our colleagues from GI joining as well, and if anyone wants to share additional thoughts. Thank you so much.
Thank you, Reem. That's great presentations. It's clearly not, it was not an easy case that you highlighted the importance of having multidisciplinary discussion in this complex cases. We do not know if that's, that's our hypothesis, that this is probably just the helper 1, the helper 2 imbalances, and we think that this multifactorial causes for hypereosinophilia in this particular case is probably the best that we could think of at this point. So far, we are achieving a good eosinophil control, and also preserving the liver functions, and avoiding rejection. But happy to answer any questions you guys have, or any comments about the case, and on the approach of this case, or if you guys have any similar experience with other cases as well, maybe either transplant related or not transplant related.
Adrian, I have to leave, but to correct,
yeah.
but
You're live already.
I completely am with you on the thesis. So Reem, excellent presentation up front. I've seen a couple of patients like this, and the same, and importance of that is to kind of drive down the transplant-related immunosuppression to a point that is tolerable. Here, as I said, because of the thought that you may have a post-transplant autoimmune liver phenomenon, we use budesonide that seems to have worked well without not having that much of an effect on his growth. And then taking the cell sept off the picture, which I think personally made a difference. And as you said, Reem, highlight every time he has an intercurrent infection, his counts will bump up. And so that all kind of points to the proof, your theory that may be a likely possibility here. That's it. I have to leave. Thank you so much for having me.
Can you hear me now?
Dr. Klion?
Yep.
Yes, thank you.
Oh,
So,
sorry.
thank you so much.
My team, so I have a number of comments, and I think an idea about what the underlying diagnosis is that wasn't mentioned. So in terms of general comments, that was, first of all, that was an excellent presentation. You did a huge and very careful workup, and so that was great. There are a couple things that I think are important to note. So I'm an adult medicine person, but because at the NIH we see both pediatrics and adult, I see quite a number of children, as you probably know. The most common cause of eosinophilia and hypereosinophilia greater than 1,500 in adults and children is allergic disease, drug reactions, and parasitic infections, and that crosses the board. So it's not specific to children, it's also in adults. The difference in children is that the level of the eosinophilia tends to be higher for the same diagnosis. So if you have an adult with eczema versus a child with eczema, children with eczema have higher eosinophil counts. That being said, eosinophil counts above a couple of thousand, you really don't see except in the most severe eczema, or eczema in the setting of DOC8 deficiency or something like that. So your patient's eosinophil count when they presented, asthma, allergy, none of that is responsible. I mean, maybe it gave him a little bit of the eosinophilia, but I would immediately exclude that as a cause. The way that we typically approach patients is not different than what you did. So the first question is, do they have life-threatening disease? You have to do something. You have to give them steroids right away. If they don't, then the most important thing to exclude are things that you would treat in a way that is different than treating the eosinophilia primarily. And as I said, worldwide, the most common cause is parasites. I am by training a parasitologist, infectious disease specialist. We just presented at ID Week last year a comparison. So we see patients with both helminth infections, parasitic disease, and I see patients with eosinophilia referred for unexplained eosinophilia. So we put together our several thousand patients and looked at eosinophil counts in adults and in children in patients with proven parasitic disease versus other causes. And what I can tell you is that in adults, if you have an eosinophil count more than 20,000, the only parasitic infection that can do that is tropical pulmonary eosinophilia, which is a very specific parasite found only in certain areas of the world. It's a filarial infection. And above 30,000, you don't see it. In children above 20,000, the only parasite that causes, and we also did a big literature review, the only parasite that would cause eosinophil counts in that range is Toxocara. And again, visceral larva migrans is a very specific presentation, and your patient really did not fit those criteria, and it didn't make sense. I think it was reasonable to look for strongyloides. Immunoglobulin in a patient post-transplant is not very helpful. The strongyloides serology is not 100% specific anyway. If you have disseminated strongyloides, you can find the parasites everywhere. It's not a difficult diagnosis to make. And if you're really concerned and you can't do the parasite testing, the thing to do is just to give them a dose of ivermectin. And so I don't think your patient had strongyloides, as you didn't. I think the donor was treated appropriately for having a positive serology, but this child did not have a parasite, and I would have excluded that up front. The Addison's disease, it is in the original description. I think I agree with you that that exacerbated the eosinophilia at some time points, particularly in the context of the viral infections. Viral infection causes eosinopenia. So a normal person who gets a viral infection, even someone with hypereosinophilic syndrome, the eosinophil count goes to 0 with the infection. Then it comes back. In your case, the eosinophil count didn't go down. And so that tells me that the eosinophil count is actually being driven by another mechanism, and Addison's can do that. So the stress of having an infection and the fever and the infection likely caused an increased steroid need and may have been what contributed to that. So I agree with what you said there. The diagnosis that, and you went through the myeloid diagnoses, that didn't make any sense for this child. You had to rule it out. Just keep in mind that the FISH for PDGFRA is not very sensitive. It misses about 30% of cases. We published on that, as has one other group. And so you have to have a high suspicion, but you did the bone marrow. You didn't see anything that looked consistent. So I wasn't too worried about that. In adults and even in children, we worry about that a lot. The other thing we worry about a lot are leukemias and lymphomas. Pre-B-cell ALL can cause very high eosinophil counts. It can be very hard to make the diagnosis in that context, but you really didn't have evidence for that, and you did the B-cell clonality assays and the flow, which is what we would do. So the thing that was missing that would explain the whole 9 yards has to do with tacrolimus. And you're right that it can cause eosinophilia, but it's well known to cause EGID, eosinophilic gastrointestinal disease. And there's a lot in the literature about that. While you were talking, I looked quickly in PubMed and just typed in tacrolimus and eosinophilic gastrointestinal. And what came up is Transplant Immunology 2021, post-transplant eosinophilic gastrointestinal disorders and lymphoproliferative disorder in pediatric liver transplant recipients on tacrolimus. What's interesting is, how do you treat EGID? Swallowed budesonide. And so you're actually treating the patient for EGID. I think that that's probably the major cause of eosinophilia in this patient. He's the right patient. It happens in patients with food allergy, mild eosinophilia, eczema. They have the atopic march, and then they develop eosinophilic gastrointestinal disease. And so he might have done that anyway. And then you give him tacrolimus in the context of a transplant, and you bring that out. It would have been nice to have the EGD before he got put on all of these drugs. Now, if you do the EGD, I don't know if you're going to see it. You may not. And the other problem is that mepolizumab really doesn't work. So that if you knew he had EGID, that drug doesn't work. What likely works is dupilumab, but you have to be very, very careful with dupilumab because it can cause an eosinophilia in the blood to increase. And we've seen significant complications in patients with pre-existent eosinophilia. So in terms of what drugs you would use, we use dietary interventions, the 6-food elimination diet, or swallowed budesonide. And depending on where it is, you either use swallowed budesonide that's crushed, that works better. The pills actually go small bowel and colon. They skip. They don't work as well in the stomach, which is likely what, which stomach and duodenum is what I would worry about in this child. So getting your GI people involved and making sure that and at least doing the endoscopy, even if you see nothing, I think would be useful. But that, if I had to guess, I would say that you're right, it's multifactorial, but the major thing may have been this. And you can see these spikes of eosinophilia in EGID because they eat something that triggers the disease to worsen. So anyway, those were the major things. I think everything else that you talked about, I pretty much agreed with. One thing that I will say is that I know Jason put amoeba on his list of things that cause hypereosinophilia. Amoeba does not cause hypereosinophilia. You can get local tissue eosinophilia with amoebic abscesses, but you do not get peripheral eosinophilia. So protozoa in general don't. The exceptions are Sarcocystis and Cystisospora, but none of the other ones do. But that's just that's very, very specialized. Anyway, hopefully that was helpful.
Yeah, that was very helpful, Amy. Thank you so much for the insights. I think, I wish Dr. Krishnan was still here, so I would like to hear his thoughts as well as far as the initiation of budesonide. I know Reem already mentioned reasoning, part of it to preserve as additional immunosuppressive, but I don't know whether he had thought about EGID as well, actually, in these patients, because we actually have not done EGD in these patients. And thanks for that comment about the Dupixent. There was a question in the chat about peripheral eosinophilia following initiation of the Dupixent.
So that's
Can I ask one
reported.
question?
Yeah, I mean, so just let me answer that. So that's reported. So I was an author on the study that was published by the company where we looked at all their phase 3 trials, and they made the point that it was relatively uncommon. But remember, the people enrolled on the trials were not people who had eosinophilia hypereosinophilia to begin with. We recently published a paper where we looked at people with a pre-existing peak eosinophil count of greater than 1,500. We saw a rise of eosinophil count, above 1,500 and sometimes very high in 50% of patients. And we saw patients who developed significant eosinophilic complications, including eosinophilic pleural effusions and eosinophilic coronary artery dissection. So this is really a problem. We don't give dupilumab to people with high eosinophil counts because of the risk. No, you can't start it on a steroid taper. I think it's a dangerous drug to try alone. If you can suppress the eosinophilia with mepolizumab or benralizumab, we currently have a trial ongoing where we're adding dupilumab to mepolizumab or benralizumab. And we know that will suppress the eosinophilic bump and you still get the benefit of dupilumab. But then you're committing a child to dual biologics. He's a little young for mepo, almost there. And, do you really want to do that? The IL-13 drugs in general, no. They've been associated with eosinophilia, some of them. Tralokinumab, I'm not 100% sure. I can tell you that that lebrikizumab can cause the same thing as dupilumab. Tezepelumab doesn't, which is a TSLP antibody. It really depends on the specific antibody. I'm sure I've looked at tralokinumab, I just don't remember.
And Dave, it seems like you have questions.
Yeah, just one question, comment. Were they also on Vori or Posa or a P450 inhibitor?
I don't recall that our patients on any antifungal.
Okay, because that sometimes can make the tacral incidence of this even a little bit higher. But more importantly, don't forget that because of, you said budesonide doesn't have good bioavailability because of the intrahepatic recirculation, or I'm sorry, because of the high first pass metabolism. But that will be almost fully gone with Vori and Posa. So you will actually get almost 100% absorption of the budesonide. So even 3 milligrams of budesonide is like 45 milligrams of pred in those patients. So just don't forget that part.
Yeah, I don't think our patient on antifungal.
Okay. A lot of livers are, so I just wasn't sure.
Any other question? Could you start Dupixent on a steroid taper?
No, that's what I said. Even on the steroids, I wouldn't start dupilumab in somebody who has an eosinophil count of 2,000. I think it's a dangerous drug to start as monotherapy.
Mhm.
And our patients, almost all of them are on steroids when they get put on dupilumab, and we've seen really significant complications. So I don't think that that's a useful drug. And the data on, so there's no data on, so the person who asked about tralokinumab, there's no data for any of the other drugs for EGITs. The only one that's approved is dupilumab, and it's approved for eosinophilic esophagitis. It will soon likely be approved for eosinophilic gastritis, but none of the other ones are approved. Benralizumab works to some degree. There's no data in children of this age, but we know we published that as a side publication of our phase 2 trial. And we will have data, a little bit more data on our phase 3 trial soon. The phase 2 trial that was devoted to eosinophilic gastritis, it didn't meet endpoint, but that was out of Cincinnati, but it did have effect in some people. So benralizumab works a little bit, but mepolizumab really has not been effective for eosinophilic gastrointestinal disease in general. But swallow budesonide works. It's just that you would want to, depending on where the disease was, you might want to crush it into a slurry. You might want to, you have to determine how you would administer it for the optimum local effect. And we don't care. When we do that, they still sometimes will have a mild peripheral eosinophilia in the couple thousands, and we ignore it because it doesn't make a difference. You just want them to be clinically well.
Thank you. And then I have more philosophical questions, I guess, with the IgE and eosinophils. Sometimes they correlate, sometimes they don't correlate. Amy, do you see that as potential explanation, like hints for potential explanations at all? Like this patient IgE was completely normal, so
that's IgE is not helpful. The only time I'll take that back. The only time IgEs are helpful, so they're not helpful in ruling in or out parasitic infection. They're not helpful in deciding whether somebody has atopic disease. Where they're helpful is when it's 20,000 and you have severe eczema and you think the child has DOC8 deficiency or one of the hyper IgE syndromes. Then if the IgE is normal, they don't have that. So it's useful in that context. In patients with myeloid disease that involves mast cells, including PDGFR-A and KIT, IgE tends to be very low, undetectable, but not always. I had a patient with schistosomiasis and PDGFR-A with a high IgE. You know, we treated his schisto and went down. So it's not, it doesn't really help me one way or the other.
Unless they are extreme. Unless they are at the extreme level.
Right. And even then, you can have people, I had a patient with 70,000 IgE, an older man. I don't know why. We ignored it. I mean, it wasn't doing anything. So I don't know. IgE is not super helpful except in very isolated circumstances.
Yeah. And that similar case, very similar case that we have recently as well, has IgE of 47,000 in a setting of uncontrolled eczema. Older patients, 18 years old. But the eosinophil is not as high as this patient. I think the highest was 15,000, but you know, steroid and then on maple right now, and doing fine. But we ruled out hyper IgE. We send genetic testing. There's no hyper IgE syndromes.
Well, but so you may have sent genetic testing, but I wouldn't rule it out. So there are people, we've had people with occult DOC8 where the genetic testing came back negative, but the functional testing showed a DOC8 deficiency. And then when we did deeper sequencing, the patient actually had DOC8. Now, if they don't have a history of recurrent infections, then then it's much less likely. But there certainly are, we rely on genetic testing. Genetic testing can be wrong and it can miss things if the mutation isn't exactly what they're looking for. So I wouldn't rely 100% on that. I would always rely on your clinical judgment. And, if they're doing well, mepolizumab does not work for eczema. It doesn't work very well for skin itching. So I don't know that the mepolizumab, I don't know what it's doing.
Yeah, we'll circle back with you. He's been on it for 2 months now, so we'll see. If we have issue, we'll reach out to you. But thank you so much for your input for this case. This is very helpful, and obviously the reason why we presented this case is, hematology is part of the team that usually get involved, right? And as part of NICER, we have multiple other subspecialties as well. I think it really highlights the needs of having multidisciplinary discussions among ourselves in both adult or pediatrics for tackling patients with hypereosinophilia, because it's always very challenging.
No, I'm very impressed because that is the mistake that everybody makes. Hematologists need to know about eosinophilic granulomatosis and polyangiitis, and allergists need to know about hematologic malignancies, and because otherwise you're going to miss really serious diseases because they're out of your subspecialty. So thank you for thinking out of the box. It was a really nice presentation.
All right, I think we are at time. Thank you so much for attending. And then there's a code for claiming your CME.
All right, thank you.